Okay, good morning, everybody. I'm Patricio. I'm one of the pediatric surgeons at Nicklaus Children's Hospital. I'm just going to be giving a quick talk on a case of pediatric trauma. And of course, I'm giving it away, but it's a non-accidental trauma case. And throughout the presentation, I'm going to sprinkle in some information on non-accidental trauma in children. And start. So nothing to disclose. The main objectives of the presentation is going to be to describe, diagnose the different modalities that we use to identify cases of non-accidental trauma and recognize some of the physical findings that you can find in these children that will clue you in that these children might be experiencing non-accidental trauma. So the reason why I'm presenting this case is because pediatric surgeons and surgeons in general, trauma surgeons in general, are in a position that they can identify these patients, and a lot of these patients can present to you in a they can have severe trauma that can be inflicted on them, and you might be treating this trauma without realizing that they are that the source of the trauma might be somebody that might be taking care of them. So even the ACS Trauma Quality Committee and the American College of Surgeons have come up with different tools and guidelines that they have developed in order for us to be able to identify these patterns, and that will clue us to better identify these patients and be able to protect them, to help them. So just to go ahead, we'll start with the case. It was a 3-year-old female who had a history of a sickle cell trait. She presented to the ER initially with some swelling in her right side of the head. The parents stated that 2 days prior to her presentation was watched by the mother. She climbed the crib and she fell over the crib and hit her head on the floor. The crib was about 3 feet high, which is about 0.9 meters. She did not experience loss of consciousness. They picked her up. She had no complaints, no problems. She was eating okay. So they didn't think much of it, they said. The day before they came in, the parents said that she was banging her head on the railing of the crib in the evening. And they started to notice some swelling on the right side of the head. And that's what prompted them to bring the child to the emergency room. The mom says that when you place her on the crib, she acts angry and she starts banging her head. But nothing else has been noted at home. She has been tolerating a diet, no vomiting, no nausea, no fevers. She's been alert and as usual and acting as normal per her parents. Just a quick picture of the physical exam. Hemodynamically stable. GCS is 15, is appropriate for her age. The things that you notice, though, is that she has some bruising on the left side of the cheek, is oval in shape, and she has some scars and bruisings on the legs, and then you notice some swelling on the right parietal, occipital, temporal area. Aside from that, the rest of the physical exam is completely normal. This is a picture of the child, and you can notice the bruising on the left cheek here. So now I have questions for everybody around. So what do you usually do in these situations when they present to your emergency room?
Thank you, Dr. Lau. Dr. Andre, do you have any consideration to make, please?
Were you calling on me, Dr. Patricio? Yes. Yeah. Well, and a giveaway from the title of the presentation, but also the old bruising, and not just on the head, but on the legs, and you said the legs and the face and the head, both sides of the head, and anything on the back of the child, the buttocks or the back of the child. That I think you didn't point any of those out, that there weren't any. Is that correct, Dr. Lau? Okay, well, I assume there weren't, but anyway, certainly even without the title of the talk, that old bruises and different parts of the body where you wouldn't expect them, on the legs, and certainly if any bruises on the back, that wouldn't, the child couldn't have done those herself, or on the buttocks, and you'd be concerned about child abuse. So you need to do a careful exam, try to look at for petechial hemorrhages in the retinae, if you can see them, if you can do a proper exam, complete ENT exam, look at the tympanic membranes, and then have the child evaluated neurologically. So if she has the bruising on the side of the head, that could be with sickle cell trait. I don't think that should be that there should be any trouble with hemostasis that would make her more likely to get hematomas. As far as I know, that wouldn't be an issue. But I would do the complete physical exam, looking for signs of bruising. Maybe consult a neurologist to see if they need to do anything more, like a CT scan. But I would certainly pursue that, given the old and the new injuries.
Perfect, perfect. And any specific labs that you would like to order?
Well, a urinalysis to look for hematuria, and perhaps looking for myoglobinuria, and yeah, the others I'm just guessing off the top of my head. Actually, that's all I can offer.
Great, great. And you mentioned imaging. You mentioned a CT scan.
Perhaps,
Perhaps.
Certainly, maybe a skull X-ray, perhaps a skull X-ray to look for signs of a fracture. And certainly, if there's a fracture, I would do a CT scan. I would, in my case, I would ask a neurologist, or probably a pediatrician who is more expert, expert in child abuse, to see, get their opinion. Perhaps go straight to a CT scan if my expert said so. But I would start with a plain film of the skull to look for a fracture.
Perfect, perfect, great, great. That's exactly all of the different things that you think about. Start labs, imaging. Do you need to call somebody else? What consultants should you get? So, like you prompted, they started with a X-ray of the skull, and they were able to note a occipital skull fracture extending into the right lambdoid suture. So that prompted them to get a CT scan. Well, okay, so what would you do next at this point? And then I asked again what things you will get. And like you said, like you mentioned, if you had an X-ray that's pointing to a fracture, a skull fracture, then imaging might be something you will want to get. So at our institution, we actually have a protocol in which we have patients, whenever we have a patient presenting with an isolated fracture, depending on the index of suspicion that you have, you see any other red flags, and I'm going to go over some of these red flags, it will prompt you to get more imaging. And some of the red flags that you would identify in patients is, and you divide it into 3 different things. So mainly ones in the history is when the history is not consistent. If you have 2 family members or multiple family members and they keep changing the history and they said things that they don't really make sense, right? So for instance, one of the things that I pointed out was the height of the bed that was only about 3 feet, things like that. Or if they change the story, or if an injury is unwitnessed, if there's a delay of seeking care, this child presented to the emergency room 2 days after. And also you have to look at the history if the patient has been into multiple visits to the emergency room. Some of those patients, you will identify that they have a history of domestic violence. That's another red flag, of course. In small children that have low birth weight or have chronic conditions tend to be more susceptible to abuse. In terms of physical exam, one of the big red herrings is a torn frenulum. When you look at their mouth, when you say, like you mentioned, doing a head to toe, and you see that there's a frenulum that is torn, or if they have failure to thrive. Failure to thrive in children, it's a telltale sign because the child is being malnourished. This kid specifically, her weight was negative 1.6 in the C-score, so she was quite underweight. Large heads, any bruising, of course, like we mentioned, and we're going to go over a little bit more on this bruising and these marks further in the presentation. scars, different things like that. And if you do end up getting radiologic imaging, like X-rays, specific fractures in the metaphyseal plates, rib fractures, if you have any fractures in children who are non-ambulatory, that's a big red flag as well. And of course, skull fractures that have any sort of bleeding, subdural or dural hemorrhages. Yes.
And please, as a moderator, we have brilliant surgeons waiting to comment about the first question. Could you please stop to the other surgeons comment, please?
Okay.
Yes, thank you so much. Dr. Collet, do you have any question or any comment about the first question of Dr. Lau?
No, I have no comments because it's very difficult to us when you have received a child in the hospital. The great problem of on this situation is the history is very difficult to take the stories because childs don't speak, and usually they be family or the companies gave some no information, adequate information. So the doctor must be very clear that he needs to check all the problems. And sometimes we have injuries in the head, but we have injuries on the arms, legs, and other sometimes you have to make an X-ray on other positions of the body to find other injuries or old injuries can be suspected the problem with this child. So it's very important. And it's very important sometimes you have some specialty. People could to talk to the family, talk to the child to know what's happened. And some here you call the social service in our hospital, then try to check the problem with the family and try to interview the members of near the house, and so to find what's the problem is happening with this child. It's very difficult. And if you have this child don't have injuries that you suspect very serious injuries at this moment, but she can come back with serious injuries on the other times. So you can make very careful when you discharge and can talk with this family. And so this is a very difficult problem to resolve. And we have problems in the child, and sometimes we have problems in the older people. They have the same things in the same times. So I think it's very good. It's very important to have the protocol to identify how to treat this child.
Thank you, Dr. Collet. Dr. Alex, do you have any comment?
So we're not a pediatric trauma center. Occasionally we get some patients, and usually what we do for them is just primary, secondary survey, stabilize them, and then we send them. It's actually really close down the road to CHOP. If a patient like this would come to the ER, obviously the delay in presentation is a red flag, as it was mentioned. It may be appropriate for the kid to climb out of the crib for a 3-year-old, but I agree that crib is kind of high at 1 meter. Just looking at the picture of the face, definitely eye exam, and I would add to the physical exam just to look in the mouth, see what's going on there, any other signs of trauma. And anything else on the body that would look suspicious, I would x-ray that. And the banging on the head on the railing of the bed, that's kind of unusual. I'm not really buying that story unless the kid has a history of cerebral palsy or something like that of that nature. But I'll definitely get all the labs, basic labs, trauma, coagulation profile, look for records, other presentations to the ER before, if the patient is vaccinated, everything that would suggest that he is taken care of. And if those are missing, that points more towards a neglect or abuse. and then probably scan everything. Thank you.
Alex. Dr. Lau, please. Thank you so
Yes, no problem. So, like we mentioned earlier, there's protocols that different institutions have. This is one of the protocols that we go by. In terms of labs, the specific labs that we get are CBC and coags. Bruising in children could be pathological as well. It could be some condition that they might have, immunologic condition, hematologic condition they might have. So you have to make sure to rule that out as well. You get a CMP to look for the liver enzymes, a lipase, a UA, like we mentioned earlier, to look for hematuria or myoglobinuria. And in children that has fractures, you would also look for, you will get a phosphate, a PTH, and a vitamin D level. In terms of radiology, like a lot of the panelists have mentioned, we do something called a skeletal survey, and I'll go over the skeletal survey a little bit later. And essentially, we have X-rays of different areas of the body, trying to identify all fractures or current fractures or fractures in different states of healing. And if there's enough index of suspicion or any head injuries, you will get a CT scan of the head. Especially in children less than 6 months of age, if there's a history of abuse or suspect abuse. Children will have bruises in the face that are less than 12 months of age, and anybody with neurological symptoms. And CT scan of the abdomen was something that you will be prompted off based on findings or your index of suspicion of any other injuries that the patient might have. In terms of consultation, like somebody else mentioned, if you're a center that doesn't, you usually don't see children, consult a pediatrician, and like somebody else mentioned as well, social worker. A lot of places have interventional, or not interventional, but social workers that are specialized in abuse. So they can start asking questions to the family in specific ways, and they can start evaluating the whole situation of the family and see how safe the environment is for the child. And of course, depending on the injuries that you see, you might consult neurosurgery or ophthalmology for the eye exam, a retinal exam, and other members as well. This specific child ended up getting a CT scan of the head afterwards, since they had the original fracture. And in the image, you can see that it's overall, at least in the parenchyma of the brain, negative. They can see the fracture. They can see the non-displaced fracture on the occipital fracture that extends into the lambdoid suture. But overall, the head CT is not that concerning. There's not a large intracranial bleed. There's a hematoma that is seen, but overall, the CT scan of the child is okay. Do we have reconstructions? Our radiologists do a 3D reconstruction of the CT, and you can see the fracture on this side. The labs that we order overall were negative, except for a hemoglobin of 9.5, which it looked more like an iron deficiency anemia more than anything else. It wasn't concerned for any active bleeding. The patient was hemodynamically stable throughout the whole evaluation. The patient was appropriate. There wasn't anything concerning to make us think that the patient was actively bleeding. But everything else was normal. The CMP was normal, liver enzymes were normal, lipase amylase was normal, and the UA was negative for hematuria or anything else. We did the bone survey. The bone survey, like I mentioned, it's X-rays of different parts of the body. And aside from the cranial fractures, it was negative. No rib fractures, no long bone fractures, nothing else. A skeletal survey, it's a tool that we use that like I said, it includes X-rays of the humerus, the forearms, the femur, lower extremities, the hands, the skull, cervical, thoracic, and lumbar spines, and the pelvis. And gives us an idea to look for any areas of healing And if you suspected that the child has any history of abuse, or any child less than 2 with history of abuse, you should get one of these in order to have a better idea of to look for these other injuries. At some places at our institution, we would automatically order a skeletal survey in children less than 2 with obvious signs of abuse, or if you have any suspicions of them, or bruises in a child that is non-ambulatory. They have a phrase that they say, if you don't cruise, you don't bruise, meaning that if you're a child that is not walking around, not cruising around, it shouldn't the child shouldn't be having bruises. So that will prompt you to obtain one of the skeletal surveys. Again, if there's any oral injuries, it will prompt you as well to get a skeletal survey to rule out any other types of injuries. So what would you do next? At this point, you have a child who you're suspecting there might be an injury. You have a CT scan of the head that shows a skull fracture, but not a brain bleed. Labs are relatively normal, has an anemia, microcytic anemia. But aside from that, the child is doing okay. Would you consider discharging the patient from the emergency room or admitting the patient?
Thank you, Dr. Lau. Dr. Alec, any comment, please?
I would not discharge this patient home in the care of the parents. I think pediatrician should be involved, the neurosurgeon should be involved. Given the sickle cell trait, probably hematology should weigh in. I'm not sure there's much they can do, but maybe start on iron supplements. I would get the social worker on board, and I think an investigation should be started and find exactly what's going on in that family, if it's a safe place for that child to return over there. So yeah, I would not discharge this patient.
Thank you, Dr. Alec. Dr. Collet, any comment? Dr. Collet, can you hear me? Dr. Antrak, any comment, please?
Yes, Dr. Collet, I think he's texting or something. But anyway, I agree that you can't discharge the child, and when the parents are there in the hospital room, obviously the nurses need to be need to supervise, and then the report needs to be made to the county Child and Youth Services. So I don't know how the protocol in the hospital. But physicians are mandatory reporters. If I were seeing this child, I would make the report. Even on seeing the skull fracture or the signs initially, something I should have said before, I would have just made a report. And you can go online and just give notice, and then you need to tell the hospital CEO that you've done that. But I think one report is all you need. So as long as a report gets made, but if you don't make a report, and then the other people, the hospital staff don't make the report, or the social workers don't make the report, it's on the physician. So I think it's just safest to make the report. It's a misdemeanor in most places if you have reason to believe there's an issue and you don't report it. And I think it's the same in all states. So that's paramount. And then if that linear fracture, probably nothing needs to be done for that. It'll heal, but I would certainly ask the neurosurgeon what they thought about it. And then otherwise, those bruises, you can see the hematoma in the skull, that'll resolve. But I think this child needs to stay in the hospital for those social reasons. And it's in fact good that you found this before there was something irrevocable, like a brain bleed or retinal hemorrhages or serious trauma that's gonna injure the child for life or worse.
Thank you, Dr. Antrak. Dr. Epstein, any comment?
Yes, I'm here. I just had to unmute. No, I agree with everything and had taken care of many children over the years. I think you just tell the family that the kid has to stay for observation. You don't need to create any problems within the hospital or the family. And it's just told to them, you know, very nicely, very kindly, no accusations, and then continue to go ahead with a report and any further investigation at home.
Thank you, Dr. Epstein.
You're welcome.
Dr. Kaufman, any comment? Okay, Dr. Lau, please.
Okay, great. Thank you. Where would you admit this patient? You think she needs an ICU? Should she go to the floor? Based on the findings that we have so far, where would you place the patient?
May I comment? Perhaps if you're going to admit the patient, which you have to do, of course, you admit him to a room where you can observe interaction with family. I wouldn't put him in the ICU, but I wouldn't put him out on the floor without any supervision of the family.
Okay, great. Perfect, good.
Thank you.
And like you mentioned earlier, consultants, and I think everybody has made a great job at noting that if you're not a pediatric hospital, you will consult a pediatrician and social workers. And of course, neurosurgery, that although we don't think that they're going to necessarily do something for the injury, they should weigh in the evaluation of the patient. So this child was admitted. The neurosurgeons were consulted from the ER, and they recommended to observe the child, no surgical intervention. The pediatric surgery team was consulted at that point, and we admitted the patient. We put her in our surgical floor. Our surgical floor, unfortunately, we get a lot of patients like this. So our surgical nurses are used to evaluating the patient. They tend to, patients that are like this, they tend to have a higher, a lower ratio of nursing per patient, meaning they can be more attentive and keep an eye closer on the child more often. And they observe them with a closer eye. Of course, since there's no surgical interventions to be done, the patient was placed on a regular diet. She was tolerating PO just fine. Her vitals were stable throughout. No neurological changes that she experienced, and the social workers were called to evaluate the patient. Like we mentioned earlier, the social workers got in contact with the Department of Children and Family, automatically filed a report, made contact with them, and they essentially evaluate the history of the patient or the family to make sure that there's no other holds, to make sure that there's no other history of abuse, or if there's a dangerous home or anything like that. When they contacted all the supervisors, they contacted everybody else from DCF, and overall everything was negative. They had no history of abuse. The patients, the family, they had no prior arrests. Overall, the family seemed to be a healthy family environment. So in these cases, per the protocol of DCF, is that they follow up as an outpatient. They go visit the family when they're at home, and they follow them up. But in of themselves, they don't have to do anything inpatient. So the DCF cleared the family for discharge from their standpoint, from the social work standpoint. So what would you do in this situation then? Now you have a patient that you have observed them for 24 hours, or over 24 hours. From the neurological standpoint, they have done completely well. They have been tolerating the diet. Their vitals have been completely stable. She has been cleared by neurosurgery. She has been cleared by the DCF social work folks. What would you do at this point?
Thank you, Dr. Lau. Dr. Lenin, any comment or consideration? Dr. Lenin, can you hear me?
Yeah, I came a little late to this. So I guess the kid has a skull fracture, but I mean, it's difficult. It depends. You can't really keep the kid here unless you think there's a medical reason. And you follow through all your if you reported everything and everyone's involved, but you know, sometimes there's not a lot else you can do. I don't know if anyone else has some ideas, but I mean, if medically you think the patient's okay, I don't know what else you can do.
Thank you, Dr. Lenin. Dr. Antrak, any comment?
Yeah, so what do the maybe it's not their job, but what are the social workers from DC, the child and youth, whatever you call it, their DCF or DCS, what do they think caused the skull fracture? I mean, kids falling out of a crib 3 feet shouldn't get a skull fracture. So and then the bruises and various conditions of healing. So, you know, are they saying that the child didn't get abused or just didn't get abused by this family? Is there another party involved? I guess they would have ruled that out as well. So I don't, you know, I would feel a bit uncomfortable with that. What happened to the child? It's you know, the story that the family told doesn't explain the injuries and it doesn't explain a skull fracture. But in any event, so, and I'd be interested in your thoughts, Dr. Lau, what happened to the child? I mean, it just seems incongruous, but certainly in this case, if I were the attending physician, I would be sure to require to schedule them to come back weekly, telling them, look, we have to follow up the skull fracture, everything's okay, you can go home, but we need to examine the child every week. So bring them back and then look for other signs of a problem, check the weight, be sure that the child is thriving. And I assume that the social workers would continue to go back or they're done. They don't have to go back and follow up anymore. That's the other thing I'd be concerned about. But, you know, unless they were going to go back frequently and check on the home, fine, but they might miss, you know, they you know, would miss a subtle injury and they're not physicians or nurses to examine the child. But I would certainly, even if they were going to make home visits, I would certainly see this child back frequently, especially in a situation where they think everything is okay, despite, you know, they're smoking guns. If you had multiple fractures in various states of healing, that's a smoking gun. I think a skull fracture, I don't know that there's an innocent explanation for that, absent child abuse in this case. Either the parents were inattentive, somebody assaulted the child and they weren't aware of, they left the child with someone that they shouldn't have. But I don't know that, to me, that would seem like a smoking gun, so you can't deny the obvious. You know, you can't clear a surgeon when a patient walks in the courtroom with the wrong leg amputated. They can't say, well, the surgeon didn't do anything wrong. You can't make that finding. But so I'm a little confused here. It's a twist in the plot.
Yeah, so that's the difficult portion. Like Dr. Lenin mentioned earlier, medically the child is clear. Social work, what ends up happening is that we see a lot of this type of injuries, and they follow up with a surgical team, either us or with the neurosurgery team 2 weeks after. And social work continues to see them. The DCF team continues to see them as an outpatient, meaning they're going to go visit them at home, actually, usually either the following day or in subsequent visits to make sure the child is doing okay. I think somebody raised their hand. There's a raised hand.
Dr. Michael.
Hi, Michael Weatherly. I'm a pediatric paramedic from Nemours Children's in Orlando. And my question for Dr. Lau, are there older siblings in the house?
Yes, actually, in this patient, there was an older sibling in the house.
Because we've had a couple of cases where it was the older sibling assaulted the child, either by accident, playing too hard, hit him in the head with a baseball bat. So I would kind of wonder if that had been at play, if the parents are, I guess you would say, believable that they, you know, either fell out of the crib or they didn't know how it happened, if whether maybe the sibling was involved, either purposeful or accidental.
Yeah, no, there was an older child, but it was only about 2 years older than this child. But in this specific case, it was not. That was not the reason for the injury. So unfortunately, everything checked out, and the patient seemed to be doing okay from the medical standpoint, from everything else. So we ended up discharging the patient home because there was no medical reason to hold the patient in the hospital, and there was no and everything checked out from the social worker standpoint, and they were going to follow up as an outpatient for this patient. And unfortunately, whenever we see this, this happens commonly, and there's continues to be a process as an outpatient, but there's nothing else that we can potentially do per se. Just keeping holding them in for a watch. We did that essentially. We held them in house for over 24 hours, and everything checked out. Um, does any of your hospitals have any specific criteria that to keep them in for longer, or because from our standpoint, this specific patient met all of the criteria for discharge, socially and medically? Anybody else has any other specific ways that they will manage something like this?
Dr. Lau, please continue.
Okay, so what ended up happening with this patient, unfortunately, is that 4 months after, the same patient presented with a history, same situation, presented to the ER with an ambulance transfer. She was transferred to an adult hospital after suffering a head injury. The mother stated that the patient was sleeping in bed, and she got startled after she went to check on her, and she fell off the bed. It was about 2 feet high, 0.6 meters. And she fell onto the floor that was carpeted. The mother picked her up. She was crying. She was minimally responsive initially, and then she got startled. She had 2 episodes of non-bilious emesis, and the mother called the ambulance. They took her to an adult facility. The patient got stabilized from the adult facility, and then she got transferred over to a pediatric hospital. Her vitals were stable, neurologically intact, but again, there were noticed some more bruising in the upper extremities. They noticed a left frontal hematoma this time on the left side, and there was some swelling in the ankles as well. The reason why we mention a lot of times the bruising is because there's what they call a rule of 10-4. When you see bruisings in the torso and the ears and in the neck in children less than 4, this is very indicative for abuse. So whenever you see this pattern, you have to be very concerned for abuse. And there have been studies ruling this out and seeing how this type of injuries, this specific pattern is conducive or indicative of abuse. So what would you do at this point? So it's, again, what labs, what imaging, what consults would you get?
Thank you, Dr.
So you want me to continue or open it up to the floor?
Please stop. Dr. Lenin, any comment, please, Dr. Lenin, about this specific step? Can you hear me, Dr. Lenin? No? Okay. Dr. Antrak?
Yeah, you know, I would be very, very, very angry at this point, knowing before that, look, there's something, a skull fracture the first time is a smoking gun. They got it wrong. And I think, you know, I just did last week my biennial child abuse and neglect recertification for my license. And really, I think that if there were an issue, this is the county, what you call CDF, I would call the state and say, look, I think there's an issue there. Please come down and double check just to be sure. If you have the skull fracture, unless, you know, you're, as a pediatric surgeon, if you can explain that, give it an innocent explanation. But I think there's no other way to explain what happened except for abuse, bruises in different states of healing, you know, and a setting where, you know, as I mentioned before, great, you picked it up before potentially irreversible damage is done, and now you have a child with mental status changes. So, so for starters, this time, you know, call the neurosurgeon. I would go straight to a CT scan. All the other things that you mentioned, in the workup to see if there are signs of more fractures that weren't there before, you know, to indicate other injuries. But clearly, so they got it wrong. They really got it wrong. And that happens apparently all the time. You hear reports on national news about social workers sending children home saying, oh, it's okay. And then they, you know, you have a tragedy after that. And you people are the experts and you felt you had no choice, but there should be, you know, a means to get a second opinion. If if they brought the baby and said the baby's fine, you know, that's normal, send them home. They'd say, well, I want a second opinion, you know, or somebody else said that, you know, I want a second, ask for a second opinion. But there should be, you know, if something doesn't seem right the first time, there should have been a right of appeal. And I think you can always go directly to the state. I recall vaguely that was in the material that I read, that if I thought that they got it wrong, you know, and they very well might have. They have a lot of cases to review, and it's a lot of work for them. But I would have just bumped it up to the State Department of Health. But at this point, it's too late. So you need to take care of the child and then make another report.
Yeah. So, like you mentioned, this.
Wow, a little bit more moment. There are more panelists to comment.
Okay.
A little bit. So, Dr. Kaufman, any comments? No, Dr. Alec, please, any comment?
Yeah, I mean, I agree with all of the above. Definitely, this needs to be bumped up. Obviously, there was something wrong with the system. Definitely make sure get a different social worker to start the investigation, and maybe even look into, is there any interest in the social worker for the investigation to come out clear in the first place. So I guess, and kind of look into the grandma situation more. But yeah, something is not right here.
Thank you. Dr. Lau, please. Thank you.
So the child got a CT scan straight ahead, and you can see the degree of the injury. Now she has some dural hematomas as well. The skull fractures are more extensive. You can see that is a frontal one as well. Luckily, the child is doing neurologically okay. At the time of evaluation, this is the read of the CT scan. So subdural hemorrhage, some intraparenchymal hemorrhage. There's a small midline shift of 8 millimeters. The skull fractures are more extensive. Left frontal bone fracture extending into the suture, going to the aspect of the left orbital roof. Non-depressed parietal fracture, and some occipital fractures as well. So more extensive injury. We got the skeletal survey. It showed the skull fractures, but now you can see other fractures in the wrist, a rib fracture, and another fracture in the forearm at different stages of healing. This is the final report. And there were multiple fractures this time. 9th rib, left proximal humerus, left distal radius and ulna, right distal radius, base of the metacarpals, phalanx. And there were some other areas that looked like potential healing areas as well, but it was a little bit hard to identify at that point. So, like I mentioned, fractures tend to be specific for children of use, and the younger they are, the most likely they can potentially mean non-accidental trauma. Labs were done. Overall, the anemia of the child seemed to have worsened, which was odd because now the patient's hemoglobin was 8. But they also noted that the ALT was 92 and the AST is 53, mildly elevated. Alk Phos elevated 400, which is not that abnormal in somebody with fractures. But overall, those are the labs that saw on the patient. So again, at this point, what do you want to do? Clearly, we cannot send the child home, but the question is, where are you going to admit the patient to?
Thank you, Dr. Lau. Dr. Epstein, any comment?
Well, the patient's going to be admitted to the hospital, and in my mind right now, this patient will never go back to this family, certainly not in any immediate time. I don't know if they ever looked to see if the patient had babysitters, and that's all social, and they'll tell you they didn't have enough social workers, blah, 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 blah. But I would put the patient in the ICU at least for 24 hours for observation. After all, there is bleeding in the head, and the fractures need to be taken care of. There's not a great amount of care for them. But basically, the kid just needs to be in the ICU, and she won't go home. So he won't go home with family, that's for sure. And I'd check on the other kids in the family.
Thank you, Dr. Kaufman. Dr. Lenin, any comment?
I mean, I would put this kid in the ICU. And obviously, you're going to start your evaluation again of the family. And I mean, is this kid malnourished and all that? I mean, what does this kid look like? I mean,
Yeah, so her weight was, she was underweight. She was negative 1.6 on C-score for her weight. So she's quite underweight.
yeah, she just, so I mean, she's going to be observed, and I would find a reason to keep her in the hospital until this was more worked out. Like this, you know, the brain bleed's one thing. I guess neurosurgery should be involved again. But you know, she's malnourished. She needs, you know, she needs close observation for a while. And the family, obviously, this needs to get escalated. You know, at this point, you can't accept really anything else, right? Because it's pretty clear that something's going on.
Thank you, Dr. Lenin. Dr. Lau, please.
Yeah, so
Can I
the child,
comment? Did I comment? Is this a different question, or had I already commented? No, I think if I can just say what to do next. So in this case, it's a different question you asked. So in this case, I would certainly do that. You have to report again to the DCF. But even before that, I would ask the hospital CEO to get the lawyers off the court to get a court order to appoint a guardian for this child, and then let the DCF come by and see like you went over their head this time. So you're not, you know, they get the message. It's really, you know, it's blood boiling how this turned out. And I would also report this incident to the Department of Health, to the state, at the state level above the county.
Thank you, Dr. Notrak. Dr. Lau, please.
Or Dr.
Yeah,
Alex.
so-
Patricia, Dr. Alex had, I think, a question, a comment to make.
Thank you. Yes, all of the above. I think admit to ICU for sure. The only, I mean, I don't know if hematology, you know, was involved or mentioned anything about the anemia, but there's one instance where you can like break bones like this easily, and that would be osteogenesis imperfecta. But the spiral fracture of the humerus does not explain this. So still fine, check for that, but still do everything else that was mentioned by my other colleagues.
Thank you, Dr. Alec. Dr. Lau, please.
So at the outside hospital, the patient had been bolus, and they put her on IV fluids. When she got to the ER at the institution, we consulted neurosurgery. They wanted close monitoring, acute 1 hour neuro checks. She was admitted to the ICU. Plastic surgery was consulted for the orbital fracture, the hand fractures. No interventions to be done, just to observe them. Orthopedic surgery for the extremity fractures. Again, so just a sling was recommended. Neurology was consulted as well. Ophthalmology for a retinal exam. Social workers were called again for DCF to evaluate the patient too. The morning after, or later in the day, because she actually got transferred overnight, the ICU team repeated the labs, and they noticed that there was a drop in the hemoglobin, that it went from 8 to 6.9. The patient was slightly tachycardic to 110s, but pressure was okay. What would you do at that point?
Have you ever scanned this kid's belly yet?
No, the patient's belly had not been scanned at that point.
I mean, with the LFTs initially elevated and the dropping hemoglobin, I think you have to scan this kid's belly.
Good. So the first thing that they did as this was happening, the idea of this patient, at this point, the patient is in the ICU. They had, for other reasons that we were not consulted at that point, but regardless, the patient was in the ICU. So what they ended up doing is they repeated the labs just to make sure, and there was a drop in the hemoglobin, it was real. And because the patient was a little bit tachycardic, they decided to give the baby, to give the child blood. They gave her 10 per kilo of PRBCs. And like you mentioned, the elevated LFTs and the bleeding, they decided to do a CT of the abdomen. The main reason I was going to go over the labs is because labs, you have to make sure that, like we mentioned earlier, elevated LFTs and amylase, we should prompt you to get a CT scan. UA, elevated hematuria, should prompt you to get further imaging as well. And like we said, this CT scans should be done in the patients that have these elevations. So the CT scan was actually negative. Probably there was a component of hemodilution because the baby was bolus at the outside hospital. They might have given it too much blood. And the anemia was just anemia of chronic malnutrition, chronic disease. But overall, the CT of the abdomen was actually negative. They repeated the CT brain of the child the following day per neurosurgery recommendations, just to make sure there was no significant changes. And there was no major changes. A brain MRI was actually done afterwards and showed pretty much the same injuries, and the mass effect had decreased at this point. So overall, the stay in the ICU was pretty unremarkable. The kid ended up having just moderate malnutrition, had the anemia. Hematology was consulted. They evaluated the child for the sickle trait, and it was just a trait, so they didn't feel that nothing else needed to be done except for starting the patient on iron. The liver enzymes ended up trending down by themselves. Genetics was consulted, like somebody else recommended, so to look into osteogenesis imperfecta, but usually the pattern that you see for osteogenesis is different, and they tend to be younger when they present with this type of issues. This is an older child, 3 years old, but they evaluated as well. They sent some genetic markers and different things, and overall, all of that was negative as well. The child ended up being transferred to the regular floor 3 days after the ICU stay, and she ended up staying in the floor for some time until Child Protective Services could find a place. The mother ended up being arrested. She eventually confessed having maltreated the child. They took custody of the second child. Grandmother was contacted. She was unaware of all of these things that were happening. The grandmother did not live with the mother. So the patient ended up going to live with grandmother. The patient and the other child ended up going to live with the grandmother as well. The kid is actually doing much better. She was followed as outpatient by all the different people that saw her while she was in the hospital. She gained weight. Her anemia started resolving. She got another follow-up imaging many months after to make sure that her overall brain injury was improving. She was followed by neurology, neurosurgery, and all the different teams. And overall, the patient did okay at the end. Yeah, this was a case in which the initial presentation was missed, even though everything checked out. So you had to have a high index of suspicion, and although the things are clear, you can have other avenues. Like we mentioned, we reevaluated the program at our hospital when this happened, and we had put in place other different things that we can do to, if you feel that this is not enough, you can hold the child for longer, with all the, and in order to make sure that all of these things get checked out and clear, before you can discharge the patient. So finally, if you see any things that are multiple fractures, infants with rib fractures, all of these things should clue you in that you should suspect and non-accidental trauma as a source. Of course, there's some other diseases that you have to keep in mind. Different deficiencies can generate fractures, but in the constellation of multiple things happening, you have to assume is non-accidental trauma. And then after all of the other stuff gets ruled out, then you can make sure that these other things, these other pathologies are ruled out. So in conclusion, providers need to have a high index of suspicion for non-accidental trauma. When suspected, a skeletal survey, labs, coax, UA, and head imaging in infants can be done. And established protocols can sometimes help in helping out work up these patients. Thank you for your time. Any
Thank
questions?
you, Dr. Lau. Thank you for all the panelists. Excellent presentation. So we have 3 minutes more. Any comment from the panelists? Dr. Antrak, any comment?
Yes, well, two questions. The trivial question, on the MRI, it looked like there was a lesion in the right occipital lobe, a spiral lesion on the MRI as it kept running through on the screen. There's something abnormal above the,
Yeah, so it looked like it was an older injury, like that the patient might have had, that it wasn't picked up on the CT scan because it wasn't an acute bleed.
Yeah, but no, it would look like a spherical lesion above the supratentorial, but in the occipital lobe. But anyway, and then, but I mean, in not just in retrospect, but at the time, if you were involved initially, the first time the child came in, were you?
Yes, I don't think I was on that weekend.
Okay.
I don't think it was me personally that.
Okay, at the time, I would think that the pediatric surgeon would have been convinced that there was abuse. How else do you explain the scars? So the point is, what to do differently next time? I think you mentioned, but if you're positive and the soldier's wrong, where you have a smoking gun, it's somebody cut off the wrong limb, and they say no, it's just nothing was done wrong. It's a smoking gun, or the thing speaks for itself. You can't deny the obvious, and then they have it wrong. So what to do when you're in that situation? What's the best way to approach it? Either go to the state or get a court order, because the social worker's got to be wrong. In that case, it just to protect the child. I mean, you're off the hook by reporting it to them, but morally you feel horrible that the doctors at the time, they were suspicious enough to report it. They knew or should have known that there's no innocent explanation for what the child had the first time. Anyway, that's the point that has me thinking. Excellent presentation. Thanks for presenting it, and learned a lot. Thank you, sir.
Thank you, Dr. Lau, for the excellent presentation. Thank you all for your presence, for your comments.
I have one last quick question. Is that possible? Yeah, I'm just wondering, was the original skeletal survey, was anything missed on that? Because the kid was brought back 4 months later and has all these findings. And I was just curious, did this all happen in that 4-month interval, or did the original skeletal survey miss some of this stuff?
We actually went back and reviewed all the images, the original images, with the radiologist again, and they were negative.
Wow,
so it's going back to the story of this patient. It seems like mom had a new boyfriend after the initial incident, and it might have been related to the abuse at that point. So it probably escalated at that point after the new boyfriend came into the picture. So that's what ended up happening. So that's the big situation that happened with this child. But yeah, we review everything back.
Thank you.
Because we said, what did we miss? Did we miss something the first time? What, this is the main reason we're presenting. We chose to present this case because, this is a complication. In all honesty, why present that complication is because what went wrong, show where we messed up, and so other people can not make the same mistake that we did. But everything checked out. We went back, we looked again, everything was clear. It was clear by everybody else, and we had to make changes to the way we evaluated things and the way that we had our social workers communicate with DCF and DCF evaluate these patients.
Thank you, Dr. Lau. Thank you,
Thank
Dr.
you.
Burke, for your question. Thank you, all the panelists. See you next week.
Yeah,
I
Dr.
just had
Lau,
a real-
congratulations for presenting this case. Very important to show this kind of situation. And we learn a lot, and it's important to keep our awareness about what's around our patients, right? Congratulations. And congratulations, Patricio, Maya, and Valeria, for making the meeting happen today, okay?
Thank you, Dr. Martins.
You're welcome, Dr.
I just had a
Thank you for
quick
joining.
question for Dr. Lau, real fast. Sorry to sidetrack you there. Dr. Lau, you mentioned on the second visit, they were brought in by EMS, correct?
Yes.
Okay, just a real, because that's where I'm concerned. So is there anything that you would have liked to have seen the EMS do pre-hospital for that child in that situation?
So they were brought by EMS to the adult hospital facility, and then they got transferred to the ICU after they got evaluated at the outside hospital facility. I don't have the details of what EMS evaluated the patient with at the time. The only thing is that the parents were with the child the whole time when the kid got transferred. They were with the parent. They were the ones that called the ambulance. Technically, mom. It was a single mother, so mom is the one that called the ambulance. Is the mom stayed with the child the whole time. It's unlikely that she's going to abuse the child while she's in the hospital, but it's after the whole evaluation for abuse was put in place, that's when the child was completely separated. When she got to our hospital, we separated the child from any visitors, actually. So nobody was allowed to visit until later on, until they were clear by the social worker and the DCF, and the investigation was ongoing.
Thank you, Dr. Lau. Dr. Martos, any other comment?
No, thank you very much. Again, great case. It's very important to have this kind of case representation. We stimulate everybody to have a good case to contact Valeria, Patricia, Maya to schedule a presentation. And I also need to end the meeting telling everybody to look in our agenda and try to join us at Pan American Society meeting in Cartagena in November. Okay, thank you very much.
Thank you.